Chapter 14, Pregnancy at Risk, Pregestational Problems. Diabetes is separated into classifications. There's type 1, type 2, and gestational diabetes. Pathology of diabetes mellitus, diabetes in general with anybody, is an endocrine disorder of carbohydrate metabolism. It results from inadequate production or use of insulin. Cellular and extracellular dehydration occurs, and it uses fats and proteins to break down as its source for energy. Any amount of glucose intolerance with the onset or initial diagnosis during pregnancy is considered gestational diabetes. It occurs in about 7% of U.S. pregnancies. High risk factors associated with gestational diabetes is marked obesity, prior history of gestational diabetes, glycosuria, and strong family history of diabetes. Diabetes in a woman who becomes pregnant, their need for insulin usually decreases during the first trimester because the fetal needs are very minimal at that time. Insulin requirements may double or even quadruple by the end of the pregnancy. There's usually an abrupt decrease in insulin requirement after delivery of the placenta. There is a risk of ketoacidosis during this time. Risk for diabetes mellitus in pregnancy, maternal, and fetal. Maternal includes hydramnios. Hydramnios, or an increase in the volume of amniotic fluid, occurs in about 10 to 20% of pregnant women with diabetes. It's thought to be a result of excessive fetal urination because of fetal hyperglycemia. Premature rupture of membranes and onset of labor may occasionally be a problem with hydramnios. Preeclampsia and eclampsia occur more often in diabetic pregnancies than in normal pregnancies, especially when there are vascular changes that have already occurred. Hyperglycemia, due to insufficient amounts of insulin, can lead to ketoacidosis as a result of the increase in ketone bodies. Pregnancy can also worsen retinopathy in women with diabetes, and the pregnant women with diabetes is also at increased risk for familial vaginitis and urinary tract infections because of the increased glycosuria. The risk for diabetes mellitus related to the fetus includes congenital anomalies, large babies, which is macrosomia, intrauterine growth restriction, IUGR, respiratory distress syndrome, polycythemia, and hyperbilirubemia. Factors related to gestational diabetes that at women at high risk include non-white women, prior history of having gestational diabetes, marked obesity, a diagnosis of polycystic ovarian syndrome, a strong family history of type 2 diabetes. Screening for gestational diabetes usually occurs between 24 and 28 weeks gestation. It is very important for the mom to monitor blood glucose levels. This determines the need for insulin. Glucose monitoring will also occur in the physician's office by the primary health care provider. The women with pregestational diabetes needs to understand what changes she can expect during her pregnancy. She should receive this teaching during preconception counseling. The pregnant woman with diabetes needs to increase her caloric intake by 300 calories per day. Approximately 33 to 40% of calories should come from complex carbohydrates, 20% from proteins, and 40% from fats. Daily food records, weekly weight checks, and regular ketone testing can assist in identifying an individual's energy requirements to help avoid the need for insulin therapy. Maternal anemia is also a complication. This can be present before pregnancy or be diagnosed during pregnancy. Most common medical complication of pregnancy. These include iron deficiency anemia, sickle cell anemia, and folic acid deficiency anemia. These women are easily tired. They're more susceptible to infection. They have an increased chance of preeclampsia and eclampsia and postpartum hemorrhage. They cannot tolerate even minimal blood loss during birth, and possible delayed healing of the episiotomy or a surgical incision due to anemia. Substance abuse. This is approximately 4% of pregnant women 15 to 44 years old report using illicit drugs. 11.9% consume alcohol and 20% use tobacco products. Usually most of it is smoking. Alcohol use during pregnancy. Because of the prevalence of substance abuse, it's important to screen all pregnant women for substance abuse during the health history and also for alcohol abuse. During the intrapartum time, withdrawal seizures may occur as early as 12 to 48 hours after alcohol cessation. Postpartumly, delirium tremens may occur. The newborn may suffer withdrawal syndrome from alcohol. And nursing care includes sedation, seizure precautions, IV fluids. Breastfeeding is okay normally. The fetus may has a high risk for fetal alcohol spectrum disorder, which results in physical and mental abnormalities that vary in severity and in combination. Chronic abuse of alcohol leads to malnutrition, increased incidences of infection, and liver disease is high. Healthcare providers should advise about the dangers of drinking alcohol while pregnant. Cocaine use. Remember, cocaine is a stimulant, causes vasoconstriction, which increases blood pressure and heart rate. This results in increased issues with the baby as well, and decreased oxygenation. The complications include spontaneous abortion, abruptal placenta, intrauterine growth restriction due to the vasoconstriction, and preterm births and stillbirths. Methamphetamine is a very popular drug in our area, unfortunately. This leads to small for gestational age infants, infants born with low birth weights, infants that have difficulty with arousing, and infants that score lower on attention tests and tests related to verbal memory and visual motor integration. Marijuana use is used very widely. There is no hard evidence at this point that the use of marijuana during pregnancy is teratogenic on the fetus, but continuing studies are going on. Any type of smoking, whether it is cigarette smoking, nicotine, or marijuana, poses a risk during pregnancy, and we do need to advise our patients to stop using marijuana before and during pregnancy to decrease those risks. Heroin and methadone, with these, the fetus is at risk for preterm birth, intrauterine growth restriction, meconium aspiration, withdrawal, includes restlessness, shrill cry, irritability, sucking their fists, vomiting, and seizures. So these babies do go through withdrawal, just like moms would if they stopped the drug abruptly. Withdrawal may last for several days, and it interferes with maternal and infant bonding. Risk for parenting problems or abuse is high. And because of the prevalence of substance abuse, it's important to screen all pregnant women for substance use during the health history. The management of drug addiction may include hospitalization if necessary to start detoxification. And stopping these drugs abruptly is not recommended due to the possible risk to the fetus. PCP is a hallucinogen. Care for these women who are using drugs we need to observe them for signs and symptoms of drug use. And not only try to observe, but we also need to ask with their history, ask them if there is any history of drug use and how recently it was used, especially if during pregnancy. Pain relief can be affected with these women. It can be difficult to achieve. Taking certain drugs, such as narcotics, builds up a tolerance to the medication. So therefore, it may require a higher dose to get adequate pain relief. Epidurals may be their best option at this point. Nicotine, 15 to 25% of women smoke during pregnancy. This leads to very small for gestational age babies and intrauterine growth restriction. Nicotine has many carcinogenic toxins that are transmitted to the baby. Psychologic disorders present in women who become pregnant. Prevalence is about 22.5% in the US, about 1 in 4 adults. It often goes undiagnosed and untreated, especially due to the stigma for psychological disorders. It's estimated that 9.4 to 12.7% of pregnant women will have major depression. With women who do have major depression during pregnancy, there's an increased likelihood of preterm births, small for gestational age infants, or low birth weight infants. Depression can reduce the woman's ability to concentrate or to process information and to respond. So obtaining consents for certain procedures may be difficult, especially in obtaining them very quickly. Consequences of untreated depression are as follows. Remember, these women may not want to verbalize or may not be able to verbalize how they are feeling. So instead, they may appear to be irritable or withdrawn or just not friendly. There's a high risk of maternal suicide. The labor process may feel overwhelming to a woman with depression, and she may feel hopelessness about the outcome of her labor. She may not be able, again, to talk and articulate these feelings, and instead she may appear to be withdrawn. Women with bipolar disorders also have babies. Remember, there's a depressive phase and a manic phase, and treating these women depend on what phase that they may be in at the time. High-risk behaviors are common in the manic phase. Anxiety disorders. There's a cluster of anxiety disorders, as you see on your screen. With these disorders, there's a wide range of symptoms in these women when they're pregnant and when they go into labor. Behaviors that you will see will be characteristic of what disorder, the diagnosis that they have been given. So women with panic disorders may present with panic attacks either in early labor because of stress and fear, or maybe even through transition. Schizophrenia is one of the most disabling psychological diseases, and it does affect pregnant women as well. These women will have difficulty interacting with their healthcare providers and their caregivers. They'll have trouble thinking clearly and difficulty managing their emotions. They often present with inappropriate behavior. And know that medications for schizophrenia are contraindicated due to their teratogenic effects on the fetus. So women with schizophrenia are at higher risk for preterm labor, low birth weight, small for gestational age babies, placental abnormalities, and antenatal hemorrhage. HIV and AIDS, women account for 26% of HIV or AIDS infected people. Of that 26%, most are from high-risk sexual contact. Individuals, again, may be asymptomatic for a long time before they show symptoms of AIDS. Pregnancy has not been shown to aggravate HIV, but screening for all pregnant women for HIV is currently being done. They can decline that screening if the women wants to. They are normally treated prophylactically while they are pregnant. And then they are also giving prophylactic medications during labor to help prevent the transmission of HIV to the fetus. Complications that are associated with HIV infection include increased risk for intrapartum and postpartum hemorrhage for mom. Postpartum infection is high, poor wound healing, and genital urinary infections. Careful monitoring and appropriate therapy for these women is definitely needed. Heart disease and pregnancy. Many women with heart disease become pregnant. These heart disease can be a result of congenital heart defects, rheumatic fever, mitral valve prolapse, peripartum cardiomyopathy, and others. The cardiac demands during pregnancy are greatly increased due to extra blood volume. Cardiac output has to increase, and the heart rate will also increase. So women with cardiac abnormalities or diseases have a harder time meeting the high workload that pregnancy demands. There are several classes of heart disease, depending on symptoms. Class 1, asymptomatic, all the way to class 4, which means they can do not really any physical activity without having some type of discomfort. Caring for women with heart disease, watching for signs and symptoms of congestive heart failure is important. That includes edema, wheezing, drug therapy, and nutrition for cardiac disease is very important during pregnancy. Other pregestational medical conditions that may present before a woman becomes pregnant include asthma, epilepsy, hepatitis B, and you can see the list on your slide. I'm not going to go through every one of these. TB is one that we need to remember. TB in the active phase, we have to remember that mom and baby have to be separated to keep transmission from happening. Asthma, during labor or pregnancy, it may not be changed at all, or it may get worse. Complications from asthmatic patients include preeclampsia, growth restriction, and preterm births. With these women, we need to make sure they stay as comfortable as possible and that they stay hydrated. We may have to use analgesics to help them remain calm and comfortable in order to, and asthmatic medications in order to control any types of asthma exacerbation. Fetal complications include prematurity, low birth weight, prenatal mortality or perinatal mortality. Remember that even a little bit of an asthmatic exacerbation can cause severe hypoxia in the fetus. Hepatitis B, according to the CDC, they recommend that we test all pregnant women for the presence of hepatitis B surface antigen. Prophylactic treatment for infants born to women with positive or unknown hepatitis surface antigen status, and that we offer routine infant vaccination. Vaccination of children and adolescents through age 18 years is recommended if they haven't been vaccinated, and vaccinations of adults who are at risk if they have not been vaccinated previously is also recommended. Hepatitis B can be transferred to the baby or to the fetus. This transmission usually occurs at or near the time of childbirth. There is risk of becoming a carrier for hepatitis B, and that's related to the age that the person was when they first were infected. Infants who are infected perinatally have the highest risk of becoming chronically infected with hepatitis B if not treated. With hyperthyroidism, maternal implications include preeclampsia and postpartum hemorrhage if it is not well controlled. Thyroid storm is a possibility with hyperthyroidism in the mother. When diagnosed during pregnancy, the hyperthyroidism may be either transient or permanent. Fetal implications include abortion, intrauterine death, and stillbirth. Breastfeeding is contraindicated for women on antithyroid medication. Monitoring the infants with whose moms have hyperthyroidism includes serial ultrasounds to monitor for growth and non-stress tests. This should be considered between 32 weeks and 34 weeks gestation if the disease is poorly controlled in the mom. Fetal loss is high. Newborns at risk for severe neurological problems and congenital goiter are all complications of hypothyroidism that has not been treated. PKU can be a problem with the mother, with a pregnant woman. She may have this before pregnancy. Newborns are all screened for PKU after delivery and before discharge home. This is a requirement. These people who have positive PKUs need a very strict diet in order to control the enzyme that is missing. Without that, it can lead to irreversible brain damage of a fetus. Fetal defects with women who have not been treated include mental retardation, microcephaly, congenital heart defects, and growth retardation. Women present to clinic or the hospital with a pregnancy after already being diagnosed with multiple sclerosis. Usually with multiple sclerosis, exacerbation rate is reduced during the second and third trimesters, but it is increased during the 3 months after delivery. These women need extra rest, and exclusive breastfeeding for the first 2 months can help reduce the exacerbation postpartumly. Rheumatoid arthritis Pregnancy usually produces remission of rheumatoid arthritis, and then there's usually a relapse postpartum. These women are sometimes taking steroids, such as prednisone, during the first trimester, so there is an increased risk of cleft palate in the fetus. Maternal activity levels, they need extra rest, particularly to relieve weight-bearing joints. They should continue their range of motion exercises during pregnancy, and if they are in remission, they can stop taking their medications during pregnancy. Lupus, systemic lupus. With severe cases, women may be encouraged not to become pregnant. These are the implications for both mom and the fetus. TB, again, women at risk for TB are those that need to be screened. Incidence of pregnancy complications may be higher with those who present with TB before they are pregnant. Women are treated during pregnancy for active TB. And remember, with active TB, there's limited contact with the newborn and other individuals. TB complications include spontaneous abortion, suboptimal weight gain, preterm labor, and increased incidence of neonatal mortality and low birth weight. Risk for transmission to the fetus is higher postnatally. If the TB is inactive, mother may breastfeed and take care of her infant. If it is active, she cannot do either. Chapter 15, Pregnancy at Risk, Gestational Onset. The termination of a pregnancy before 20 weeks gestation or the loss of a fetus weighing less than 500 grams is considered an abortion. Abortions may be both spontaneous and induced or therapeutic. Signs and symptoms of abortion include bleeding, cramping, and backache. Treatment for an abortion includes ultrasounds, listening to fetal heart tones if the fetus is greater than 12 weeks, checking a hematocrit and hemoglobin on mom. With the demise of termination of a pregnancy, a D&C may be indicated, a dilation and curettage to remove the products of pregnancy. Spontaneous abortion means it occurs naturally. Induced means it is the result of an artificial or a mechanical interruption. Ectopic pregnancy is a pregnancy that implants somewhere other than the uterus. The embryo runs out of room. Normally, this happens in the fallopian tube and the tube ruptures. Women present with intense abdominal pain, may also have bleeding. And usually there's no way to save a fetus at this point. Again, signs and symptoms: sharp one-sided abdominal pain, fainting. It also occurs. They can have referred shoulder pain. And again, vaginal bleeding. Nursing care includes giving a lot of emotional support. If any tissue or clots are expelled, they need to be saved. And we need to prepare the woman for possible fetal loss and assess her expressions of emotion at that time while offering support. So we're going to look, if they're in the hospital, we're going to look for vaginal bleeding, the amount and what it looks like, if it's bright red or dark red to brown blood. We want to monitor mom's vital signs. We need to monitor her for signs and symptoms of shock. In order to keep up with bleeding amounts, we can weigh pads or chucks that may be underneath her for measurements. If she's being treated outpatiently, we can tell them that abdominal pain usually lasts about 24 to 48 hours, and that they do need to make sure they have follow-up care. Gestational trophoblastic disease is a hydatidiform mole, an invasive mole, and a choriocarcinoma. A hydatidiform mole risk factors are largely unknown. Pathologic proliferation of the trophoblastic cells happens with a complete hydatidiform mole. We will see the ovum. It doesn't contain any kind of genetic material. It's like an empty egg. It was fertilized by a normal sperm. And choriocarcinoma is to be more commonly associated with the complete mole. There's also a partial mole. Usually this has a triploid karyotype, which is 69 chromosomes. The normal ovum usually has 23 chromosomes fertilized by 2 sperm, or by a sperm that has failed to undergo the first meiotic division and contains 46 chromosomes. And then the other type of mole is invasive. This is similar to a complete mole, but it involves uterine myometrium as well. The same treatment that we give for the complete mole is also needed for the invasive mole. Consequences is loss of pregnancy, and there's a small possibility of developing choriocarcinoma. Symptoms to start off with are very similar to the beginning of a pregnancy. Other symptoms may include vaginal bleeding. The uterus usually enlarges as with the pregnancy, and they still have an elevated HCG as with the normal pregnancy. Treatment includes suction evacuation, follow-up care. These women need to avoid pregnancy, and in case of the carcinoma, they may require chemotherapeutic treatment. An incompetent cervix is a cervix that just will not hold the pregnancy. It tends to efface and dilate very early. There are many causes for this problem. It's diagnosed with a positive history of repeated second trimester abortions. Management for the incompetent cervix is a cerclage, and the cerclage is usually removed at about 36 to 37 weeks for the women to go into labor. Sorry, I skipped a slide, but I'll tell you about it anyway. Hyperemesis gravidarum. This can lead to dehydration, hypovolemia, hypotension, and tachycardia. These women are going to show increased hematocrit and blood urea nitrogen. They'll have a decreased urine output. They may have metabolic acidosis and renal impairment, which leads to the increased BUN, or urea nitrogen. So these women are going to be dehydrated because they're vomiting. That's what hyperemesis gravidarum is. It's continuous vomiting during pregnancy. It can last all the way up until delivery. Many women have to be hospitalized because of this. They may receive outpatient IV fluids, and then if hospitalized, they will not be able to eat anything, and it can lead to total parental nutrition. Hypertensive disorders, high blood pressure. Those include preeclampsia and eclampsia and chronic hypertension, gestational hypertension. This also includes HELLP syndrome, which means hemolysis, elevated liver enzymes, and low platelet counts. These are all serious disorders. Preeclampsia can be mild or severe. With mild, there may be very few symptoms. Blood pressure is going to be elevated to about 140 or 90, over 90 or above. They will have some proteinuria going on, about 2+ on a dipstick, or 1 gram in 24 hours, and some generalized edema may be present. With severe preeclampsia, it can develop suddenly. Blood pressures will show about 160 over 110 or higher on at least 2 occasions, or at least 6 hours apart while they're on bed rest. Proteinuria will be up to 5 grams per liter in a 24-hour period, which is about 3+ or greater on a urine dipstick. Oliguria, with urine output being equal to or less than 500 mils in 24 hours, is also a sign of severe preeclampsia. Risk factors for preeclampsia for mom include renal failure, abruption, going into DIC, ruptured liver, and pulmonary embolism. With the fetus, we'll see intrauterine growth restriction, hypoxia, prematurity, oversedation, and hypermagnesemia. And this is from the medication used for preeclampsia is magnesium sulfate. So that can transfer to the baby and be shown as hypermagnesemia and oversedation. Manifestations that you're going to see because of the high blood pressure is irritability, edema that's not going to just be in the lower extremities, but also present in the face and hands and arms, generalized puffiness. You'll see urine in the protein in the urine. They may have headaches. Pulmonary edema can be present, and visual changes such as spots before their eyes are common. Nausea and vomiting, shortness of breath, dyspnea, and epigastric pain are all manifestations of preeclampsia. Care for these women include bed rest, special diet, anticonvulsants, fluid and electrolyte replacement, steroids, antihypertensives. And of course, we're going to be checking urine protein and fetal heart rates. We're going to be checking for DTRs, which is the reflexes. With preeclampsia, you're going to see DTRs increase. If they are put on magnesium sulfate, that is used to help them decrease that excitability. Monitoring vital signs is very important in urinary output. Watching for weight gain due to edema. After preeclampsia continues, it can lead to seizures. Once it has led to a seizure, they are now eclamptic or eclampsia. Care for women with eclampsia also includes magnesium sulfate, other antihypertensives, maybe sedatives. These women will have to be watched very closely, maybe in an ICU setting. They may get Lasix for pulmonary edema. We're going to be doing hourly I's and O's, checking intake and output, along with vital signs. And these women need to be prepared for delivery. As well, in some situations with severe preeclampsia, they are also prepared for delivery because delivery is the only cure for this disorder. Seizures are characterized by grand mal type convulsions or coma, and they can occur before the onset of labor, they can occur during labor, or early postpartum period. They can have one or more seizures. Hospital care for the women with eclampsia includes labor may be induced to get delivery of the infant completed. They may have a cesarean birth if necessary. Pain relief is important. Continuous electronic fetal monitoring to assess for fetal stress and its status. Birth, if vaginal delivery, may be done in a SIMS or a semi-sitting position to help keep the blood pressure down. HELLP syndrome is associated with severe preeclampsia. This is when it progresses, and you will see symptoms such as nausea and vomiting, general malaise and fatigue, flu-like symptoms, epigastric pain. This does affect the liver and platelet count. Treatments based on severity. And with HELLP syndrome, you see a higher morbidity and mortality rate for both the mom and the infants. Preeclampsia can lead to HELLP syndrome or can change to HELLP syndrome. Both can progress to another disorder called disseminated intravascular coagulation. This is DIC. DIC is a very serious condition. It occurs in about 5% of pregnancies where they were diagnosed with HELLP syndrome. It occurs in pregnancies that have been complicated again by preeclampsia, by an abruption, by intrauterine fetal demise, an amniotic fluid embolism, maternal liver disease, and septic abortion. DIC is a clotting disorder. Some women have chronic hypertensive disease, high blood pressure without the other signs of preeclampsia. When the blood pressure is 140/90 or higher before they are 20 weeks pregnant, they can be considered to have hypertensive disorder, and it may persist up to 42 days following delivery. We want to make sure to monitor these patients and make sure their hypertension is controlled so that it doesn't lead to preeclampsia. RH alloimmunization Moms are checked for their blood type and Rh factor when they become pregnant. It's also important to know the father of the baby's blood type and Rh factor. Statistics show that Rh positive people are about 85% Caucasian, 92 to 95% African Americans, and only 1 to 2% Asian and Native Americans. This is an antigen to antibody response between the infant or the fetus and the mother. And it most commonly occurs with women who are Rh negative and they carry a positive fetus. So subsequent exposure, the first time mom is, let me say this again, sorry. The first time mom may come to contact with fetal blood type causes antibodies to be formed. So the current pregnancy will not be affected, but she forms those antibodies, and the next time she becomes pregnant under the same situation with a positive baby while she's negative, it can lead to subsequent exposure can lead to Rh positive. Blood may cause coagulation and hemolysis of the red blood cells. So it's very high risk for baby and mom. RhoGAM injections are needed to help keep this from happening. Destruction of the fetal red blood cells leads to cause for fetal anemia. Failure to administer RhoGAM can lead to erythroblastosis fetalis, marked fetal edema, which is hydrops fetalis. It can lead to the infant's congestive heart failure, marked jaundice, which is icterus, and neurological damage. History of these is very important, and mom's blood type, along with dad's, is very important in managing this disorder. A screening at the first prenatal visit is very important. If they have not been sensitized, a second screening at 28 weeks will need to be done. If they're still not sensitized, they will receive a RhoGAM. Trauma in women occurs just like with any other people. These types of trauma include blunt force trauma, motor vehicle accidents, falls, and violence. So trauma from motor vehicle accidents is the leading cause of fetal and maternal death. Women who present to the emergency room or hospital after a motor vehicle accident are at risk for preterm labor. These women who do not have problems after a motor vehicle accident will usually remain in the hospital for about 4 hours to allow for careful fetal monitoring to make sure that there's no problems going on with the fetus. Treatment for trauma, emergency treatment for trauma is as with any other person. We want to establish an airway, control any kind of external bleeding. We want to give IV fluids to replace fluids lost. And if mom's life is not in danger, again, we'll monitor the fetus for about 4 hours. Priority concerns related to trauma include maternal mortality, often due to head trauma or hemorrhage, uterine rupture. Rare life-threatening complication of trauma is uterine rupture. It may precipitate traumatic separation of the placenta or premature labor. Placental separation, remember, is abruption and leads to a high rate of fetal mortality. Penetrating trauma can cause maternal prognosis would be better than the fetal prognosis. if it's an abdominal wound that's involved. High fetal injury rate with gunshot wounds and with stabbings. Intimate partner violence is prominent in the U.S. Up to 25% of women have experienced physical or sexual violence, either by a current or a former intimate partner. Consequences of domestic violence include loss of pregnancy, preterm labor, low birth weight infants, and fetal death. Maternal complications includes higher rates of anemia, infection, low weight gain, pelvic fractures, and placental abruption. Surgery during pregnancy is not recommended unless it's essential. There's an increased risk of spontaneous abortions during the first trimester while having surgery. With radiation, you want to make sure to shield the fetus from any types of x-rays and use continuous fetal monitoring with the surgery. There's decreased amount of complications with the fetus with women that have surgery during the second trimester. During surgery, we need to remember to place a wedge under mom's hip to prevent uterine compression on the major blood vessels. Prenatal infection can occur anytime. It can lead to intrauterine growth restriction, preterm birth, and neurological damage in the fetus. Toxoplasmosis, again, can cause severe infection in the infant that can lead to death. Survivors are often blind, deaf, or severely retarded. The greatest risk of rubella, of being exposed to rubella when they are not immune to it, is during the first trimester. Complications to the pregnancy happen within the first few weeks of pregnancy. Cytomegalovirus can complicate pregnancies. We need to caution moms to avoid poorly cooked meat, nothing unpasteurized, and no contact with feces of infected cats. They need to be sure and wash vegetables and fruits carefully. Infection with the CMV virus for the fetus can lead to congenital cataracts, deafness, congenital heart defects, intellectual disabilities, cerebral palsy. And prevention for this is vaccination prior to pregnancy. Herpes simplex virus. About 50% of infants who are born vaginally to a mom who has herpes simplex virus as a primary infection will develop some form of herpes infection. So that's about half of all babies to positive moms. Risk associated with hepatitis B with the infant includes spontaneous abortion, low birth weight, preterm labor. Transmission to the fetus occurs with the virus going through ruptured membranes or infected birth canals. If they have an active herpes outbreak, cesarean birth is usually recommended. Bacteria found in about 20 to 25% of pregnant women is group B strep that does not usually affect the mother. They usually do not have any signs and symptoms. Preventing group B strep from being transmitted to the fetus and the newborn is done by antibiotic prophylaxis during pregnancy and during labor. If the mom is known to be positive for Group B strep and has received antibiotics, then the baby can be monitored a little bit longer than normal, probably, especially if they were not prophylactically treated.